Good morning. Welcome to Medical Grand Rounds. I get the pleasure of introducing today's speaker, Dr. Gordon D. Rubenfeld. Dr. Rubenfeld did his bachelor's degree at Johns Hopkins University and then went to Philadelphia to Jefferson for his medical degree. He then went to Duke University where he was a resident in internal medicine, and then he spent a year as a primary care physician in DC before heading west to Seattle to do his pulmonary and critical care fellowship here at the University of Washington. As part of his fellowship, Gordon was a member of the prestigious Robert Wood Johnson Clinical Scholars Program and actually did that at the University of California, San Francisco for 2 years. And then was recruited back to Seattle to join the faculty, and in large part was recruited to help develop a clinical research training track within the Division of Pulmonary and Critical Care. It was the first such track that was developed, and due in large part to Gordon's leadership and mentorship, remains the best such training track in clinical epidemiology and health services research and pulmonary and critical care medicine in the country. And Gordon and I can argue later about whether it's the best in North America. Gordon then was taken from us, was recruited away to the University of Toronto. It was a very sad day for many of us. Gordon is a professor of medicine at the University of Toronto, and he's recruited to be the chief of trauma, emergency, and critical care at Sunnybrook Medical Center. During Gordon's time here at the University of Washington, his research focused on clinical epidemiology and health services research around critical illness, and particularly ARDS. And he conducted a population-based study of the epidemiology of ARDS in King County called the King County Lung Injury Project. That remains today the best epidemiologic study of ARDS and was published in the New England Journal. He also conducted a number of studies in other aspects of critical illness. And in Toronto, he has continued this work, publishing widely, conducting and leading and mentoring on a number of important critical care studies. He also was one of the co-leaders of the recent Berlin redefinition of ARDS that was published in JAMA, and one of the guiding forces of the recent Surviving Sepsis campaign guidelines that were just published. Gordon had a huge impact on this program when he was here, and I thought I would just tell one story to demonstrate that. As Gordon was leaving, we put together a seminar during our Respiratory and Critical Care Medicine conference in which we did not ask Gordon to speak, but instead we had faculty and fellows in our division talk about their research and specifically about the role that Gordon played in their research. And it was really a stunning session. People talked about his role as a mentor and a collaborator. And at the end of that session, he got up to respond and was quite literally speechless. He couldn't say anything for several minutes. And if you know Gordon, you know that rendering him speechless is really an amazing feat. So Gordon is here as a visiting professor. If you like his talk today, you'll have 2 additional opportunities to listen to him speak on completely different topics. Gordon is known as somebody who can speak on just about anything for at least 5 minutes. Yeah. This afternoon at 1:30 at Harborview, he's going to give Respiratory and Critical Care Medicine Conference on evidence-based medicine, the swinging pendulum. And then Monday afternoon, he's going to give the honorary John Butler lecture, an honorary lecture our division holds for our first division head, in the name of our first division head. And that will be at South Lake Union at 4 p.m. at the Orrin Smith Auditorium. And that's about long-term outcomes in critical illness. And I believe Gordon's going to present for the first time data from a randomized trial he conducted just before leaving Seattle. So with that, Gordon.
Thanks, Randy. Of the many stories you could have told, I guess that was the most benign one. Randy neglected to mention that almost all the things that he gave me credit for, we more or less did together. He also didn't say all the mentoring and teaching I did for him, and that I'm pretty much responsible for his success. So, true or false? So this is a talk which now I apparently am going to have to cut 4 or 5 slides out of. But I'm going to talk a bit today about kind of system improvements in critical care. And by system improvements, I'm going to talk about interventions in critical care that don't rely on getting doctors and nurses and the multidisciplinary team to provide a specific treatment, but instead evidence that we have that's sort of changing the way we do things overall can affect outcome. I'm going to start talking about the mostly failed quest for magic bullets in sepsis and kind of where that's left our field feeling depressed. Confronting that, I'm going to talk a little bit about what is an apparently inexplicable decline in mortality and sepsis and critical illness, a bit about these system improvements, and then some thinking about how to move forward. So this whole phrase, the magic bullets, actually comes from Paul Ehrlich. And if you haven't seen this movie with Edward G. Robinson, it's really remarkable and apparently historically accurate. In this scene, Paul Ehrlich says, maybe one of you gentlemen remembers my staining the tubercle bacillus. I apologize for not doing an Edward G. Robinson German accent. Well, following the same idea of affinity, I compounded an arsenic preparation which, when injected in the bloodstream, combines with the microbe and destroys it like a magic bullet. Zauberkugel. And this is a fantastic idea. And Ehrlich actually invented the whole concept of linking toxins to immunoglobulins and having them target bacteria, including ricin. So he's really a brilliant guy. And as you know, this Salvarsan 606 was the 606 after 605 failures, the first really effective antimicrobial against syphilis. So it was very exciting. And it led to this sort of whole idea that we just need to find a dye that stains a bacteria and also kills it, which is awesome. And led the folks at Bayer, who started out as a dye company, to say, hey, we should get into this drug business. It seems like there's probably some money there. And they hired a bunch of dye chemists to start going on and making a bunch of dyes, sulfa dyes, it turned out. And they came up with a red dye, the bright red dye, called Prontosil, which in vitro and in vivo killed strep. And it was unbelievable. So they rolled this red dye out, and in fact, Gerhard Damack, a German scientist, tried this stuff on his 6-year-old daughter when she stabbed herself with a knitting needle on Christmas Day and saved her life. I'm not sure what IRB he got that through, but a pretty compelling anecdote for him. And here in 1936, in a series of patients with puerperal sepsis, which we never see anymore because we more or less wash our hands and a variety of other things, they were able to show this phenomenal drop in sepsis mortality from somewhere in the 30% range to 5% range. I like to point out when I use this example in other talks, there's not a single p-value in this article. There's not a logistic regression. There is actually a very smart attempt to control for confounding due to severity, because the guys who wrote this actually were smart enough to restrict their analysis to bacteremic septic shock. And there's this phenomenal reduction. And the only other point that I'll make about this study is that this is another drug, probably like statins, where its efficacy has nothing to do with what Ehrlich and Damack thought. They thought this was a dye that was staining the bacteria. Turns out that's not true at all. Turns out Prontosil is a red prodrug for an absolutely clear and non-dying sulfanilamide, which we all know works by impairing folic acid metabolism, et cetera. So I think it's kind of cool because it works for exactly the reasons that have nothing to do with what we thought. It was phenomenally successful. The problem is, at least in critical care, we're sort of left with this delusion that we're looking for this same drug. We are left looking for the next Prontosil, and we've been doing it for the last 50 years in critical care. This is actually a recent systematic review by one of my colleagues in Toronto, Damon Scales, who looked at all of the randomized controlled trials at the time in critical care and just said, what were they powered to identify? And it turns out that 74% of the trials in critical care were powered to detect a mortality effect that's basically the mortality effect of antibiotics compared to no antibiotics, so a 10% mortality difference. So that's what we've been looking for, and we have stunningly failed at this in critical care and in sepsis. I won't for this audience sort of belabor you with the innumerable immune modulators, immune activators, anticoagulants that have been attempted to be used in sepsis. I'll just mention the brief and somewhat sad story of activated protein C. which initially looked like it was pretty good in a broad population of patients with severe sepsis. Then it looked like it was either ineffective or harmful in a group of patients with mild sepsis, leaving us feeling like it should be effective in patients with septic shock, and then it turns out to not be effective in septic shock. So actually, we are left in the last sort of, depending on when you start the clock ticking, developing absolutely nothing new other than antimicrobials to manage severe sepsis and septic shock. So it's kind of a sad story, actually, and there are a variety of reasons of this, and maybe this afternoon I'll sort of talk a bit about why these things were, these studies have been hard to do and why the results appear to be so conflicting. But we have, as a field, been completely ineffective at identifying novel therapeutics. Sadly, our favorite toys, one of my favorite toys, a toy I learned to use here at the University of Washington, the pulmonary artery catheter, turns out to be stunningly ineffective as well. So this is one of many trials that showed no benefit from pulmonary artery catheter monitoring. This is the Pac-Man trial. I'm not going to go through all of this data. It's sort of a large, simple trial where pulmonary artery catheter monitoring in a group of very high mortality patients, 60% mortality patients, didn't appear to affect mortality. And actually, I think a far more interesting analysis of this study, and I can't quite get Kathy Rowan to do this. They were really smart. When they did this clinical trial, they stratified the hospitals. A lot of hospitals, even at this point, were doing routine echocardiography, Doppler echoes, PICO monitoring, a whole bunch of other minimally invasive ways of monitoring some of the same data we get from a pulmonary artery catheter. And Kathy and her group were pretty smart. They stratified the randomization by ICUs that did a lot of this monitoring and ICUs that were willing to agree in their control arms not to measure this data at all. So what's kind of cool is if you actually look at the control arms, it's a bit of a comparison between the using non-invasive monitoring for measuring cardiac output in very sick patients in the ICU and not. Now this is a little bit, it's a randomized trial. It's not exactly kosher to compare these unless you try to adjust for severity, and there might be differences in these ICUs. There doesn't appear to be much of a signal here for getting routine echocardiography, PICO, et cetera, in this patient population. So it's a bit depressing there as well. So some of the invasive and minimally invasive monitoring we do. I do have to jump in and say, because this is where, by the way, the intensive care audience just starts to roll their eyes and go, well, intensive care is different. What we study is so much more complicated. Of course we're having these troubles. We're not alone in critical care. And those of you in the audience who are oncologists and cardiologists may be smiling smugly, but the truth of the matter is you've promised a lot and haven't delivered either. I told you they wouldn't have me back, Randy. I hope you've read this book by current and former UW authors, Rick Deo and Donald Patrick. It's an awesome read and very depressing and I'll tell you, most of the examples here are not from critical care. And Gil Welch, who's a brilliant clinical epidemiologist at Dartmouth, has sort of presented here this sort of oversold hype of screening for cancer. So I just put this in as an apology for the intensivists in the audience that we're not alone. So that's the bad news. Here's the good news that I got to tell you is challenging to sort of explain. So what we know about severe sepsis is, at least looking at administrative data, the incidence is going up, the severity is going up, and case fatality is falling. Now, how do we explain that, given the fact that we haven't come up with, all that we've done is shown that stuff doesn't work? Well, some of it can be explained. Randy mentioned the Surviving Sepsis campaign, which was both a bit of guideline development and also a large global sort of quality improvement project. And what this study showed was a reduction in mortality from sort of in the mid sort of 36, 37% to 30% by rolling out a guideline adherence quality improvement project. You might say, well, it's no magic bullet, but you know, absolute risk reduction of 5-6%, that's cardiologic in range. Like, we're impressed by that. That's a number needed to treat. That's 15 to 20, that's awesome. But why? How could this possibly have worked? Now, there are a whole bunch of methodologic reasons why these data might be challenging. But what's really amazing about this is the quality improvement intervention wasn't all that effective. In fact, as a lot of quality improvement interventions are, it actually didn't change practice by a ton. So the adherence to the entire bundle of therapies improved by a relatively small amount. Maybe say 10% adherence to the bundle to 15%, say, for example, or 18 to 23%. So the actual adherence to this entire bundle of practice, and if you kind of do the math, That means if 100% of people adhered to patients' guideline bundle adherence versus nobody, like that would be a reduction in mortality and severe sepsis from 41% to 8%, which is in fact sort of magic bullet range. So there are probably lots of other things going on here other than adherence to this therapy, and there probably are some methodologic and bias issues involved. But nevertheless, a small adherence to this. What's even more amazing is the fact if you actually go through the bundle, which was developed before, say, the last 5 or 6 years of kind of disappointing trials, most of the things on that bundle are no longer evidence-based. We now have reasonable data that most of them actually don't work. So for example, the activated protein C drug, the good news was nobody was actually using it during the quality improvement anyway, so they didn't change that very much. We now know that strict glucose control actually doesn't work or might be a bit harmful. Low-dose steroids at best doesn't do very much, except get you off a little bit of vasopressor, so that doesn't do a ton. There's an early goal-directed resuscitation protocol that I won't go into detail on, the details of which are now being tested in 3 international randomized controlled trials. So it's very likely that this, at least the intensive version of this, won't withstand the test of multiple trials. So what we're left with is measuring lactates, blood cultures, antibiotics, and probably early recognition in fluids, which is pretty awesome. And it turns out, in fact, given some data from Anand Kumar, in fact, that actually very early antibiotics and fluid administration may have an effect that approximates a magic bullet. So that may be it. What this study says to me, though, is that the sort of concerted attempt to roll out some simple things can have a very important effect on mortality in this disease. Now, to be fair, I've kind of skipped over a whole bunch of data that we do have a good idea of what works, either because we have really strong priors that the treatments are effective or they're pretty safe, or we actually have pretty good randomized controlled trial evidence. But none of them are terribly, terribly exciting. There's no new technology here. A lot of it is telling us not to do stuff that we used to do that was probably harmful. And I'm just going to go through these pretty quickly. Again, the intensivists are probably familiar with a lot of these. So we have a pretty good idea that less sedation, protocolized weaning, and early mobility is a good thing. It gets you off the ventilator faster. It probably improves at least functional status and may improve long-term outcomes. We have a lot of important questions that remain about how to implement these things, the safety of doing them, what the barriers are, what their costs are, whether dancing plays a role in the intervention or not. One of the physiotherapists I work with took this picture. I thought, because I, look kind of cute dancing with the patient, she said it was to prove that actually I come to the ICU and attend from time to time. So, and again, these are the data that we have. Again, we could certainly debate on the details of the protocol, but early fluid resuscitation in patients with severe sepsis, and in fact, monitoring and identifying high-risk patients who don't look that sick, but who are quite sick because they have high lactates, and resuscitating those patients is probably quite effective. And again, to come back to stuff that's near and dear to the University of Washington and Randy Curtis's research program, we actually have a reasonable amount of evidence around how to work with families. Either because we have data for it, like we do for preemptive or early ethics consultation and communication, or because we have randomized controlled trial that it improves outcomes for families, like we do from data from France that Randy's group informed the intervention for. And I think these are things that we certainly know improve. Do we have lots of remaining questions about these areas? Absolutely. But are these things that ought to be sort of rolled out now? Again, an area of great local interest, we now have, I think, very compelling evidence that reducing tidal volumes and plateau pressures in patients with ARDS improves mortality. Lots of important questions remain about how to do this optimally. Too many to go into in this venue. Doesn't mean the question's answered, but for sure this has improved mortality and might account for the mortality reductions that we've seen. And we know across a broad population of patients that blood is bad, whether it's general ICU patients, whether it's patients who are having myocardial infarction, whether it's elderly hip fractures. What I should say is that transfusing patients beyond, say, a hemoglobin, and I apologize when I slip into SI units, so if I tell you the hemoglobin's 80, you won't do what I do the first time in the ICU in Toronto. I said, the hemoglobin's 80? Which didn't get me nearly as upset as the creatinine of 230. I guess I should say that transfusing patients beyond a hemoglobin of 7 or 8 doesn't appear to confer any benefit. And we have a lot of biologic rationale to think that it's harmful. So these are the things, and I could go on, and maybe I have. No, I haven't. These are the things that, those were the Randy slides. These are the things that we actually know work, and we have a good idea that work. What we don't know is how to make sure that they get delivered every day to every patient in every ICU. And those are some of the challenges. So the idea and the question for the bid here is, for the rest of this talk, is absent the evidence that of a magic bullet in the ICU, we're waiting for it, let's say. What do we do in the meantime? And there are a whole bunch of interventions that one might target at the level of the intensive care unit that might have an effect on this. Intensivist staffing, namely how do you organize from the physician side your intensive care unit? Subspecialty intensive care units, is it best to have sort of one giant uber general intensive care unit, or should you have a neurosurgical ICU, a neurologic ICU, a coronary intensive care unit, a transplant unit, a thoracic ICU, et cetera, et cetera? What about high volume? We have some data from high volume intensive care units. It's actually mixed data, might improve outcome. Should we regionalize intensive care, sort of the way we regionalize trauma care and STEMI care, move all the septic patients to Harborview? Telemedicine and informatics, there's some interesting data coming along about the role of telemedicine in reducing mortality. There's a whole bunch of interesting data about variation in utilization of intensive care units. Is there something to be targeted around how we make the decision to put somebody in the ICU? And how might we use non-physician clinicians to improve outcome? So the good news is I'm only going to touch on 3 of these, mostly because they're either areas that I find particularly interesting, areas where I've published on, or areas where important people from the University of Washington have published on. So what about the intensivist model of care? So this is interesting, and I think maybe now in 2013, certainly in Seattle, this is well, of course. I can tell you 10 years ago, this was an incendiary topic when these papers came out. And still in some places, it's an incendiary topic. And the idea here, and I think it's really important to understand, and particularly when I present one of the papers to you, this doesn't talk about who your doctor is going to be. You know, we have a lot of data, say, for example, whether you see an HIV specialist as your personal physician versus not for managing your HIV care. This is, the data here is more or less all of the data that exists is about how your ICU is run. So is there an intensivist that oversees the management of care in that intensive care unit, as opposed to whether some of the patients in the ICU are looked after by an intensivist and others by a primary care physician. And the data, to be fair, you'll hear me talking in a very Bayesian fashion, and that's this afternoon's talk. Obviously, I have a bias in the direction of thinking intensivist management is, because of that, I tend to give a big pass for some of the methodologically challenged studies in this list, and I'm going to focus on the one weird one that goes the other way. The signal for almost all of this literature is in the direction favoring intensivist management. Having said that, it's a dog's breakfast, as we say, of pre-post studies, of mostly academic medical centers that have become organized. And it's fair to summarize some of this literature to say that intensivist staffing is important because it protects patients from house officers. One might say that. There's better data, I'll say there's broader data than the data that were in this systematic review by Peter Pronovost. I'm going to focus on the one outlier study. There are actually 2 outlier studies that suggest that intensivists are harmful. The one red dot there is from Turkey, and it's a very, very strange study, a very small and strange study. But the study by Mitch Levy, which is all the more interesting because I believe, if I'm not wrong, Randy, Mitch published this study of intensivist harm when he was the president of the Society of Critical Care Medicine. It's a fascinating paper, and I'm just going to focus on it in a minute because I think its uniqueness actually sheds a lot of light on this question. What they actually looked at was not whether an intensivist runs your intensive care unit, but who your doctor was, whether you individually were being looked after by an intensivist or not. And the reason that's important is because in this study, most of the patients in most of the hospitals were in ICUs where you might be admitted to an intensivist, say, for example, if you're really, really sick, or you might not be admitted to an intensivist. You might be admitted to a hospitalist or your primary care doctor. So there's a huge indication bias in most of the patients in this study. Having said that, when a very smart reviewer asked them to compare the intensive care units where all of the patients were looked after by an intensivist, to the intensive care units where essentially no one was looked after by an intensivist, there was still a harm signal. So it may or may not reflect this sort of, is your ICU managed by an intensivist or not? But it sort of gets at it a bit. So the question remains, are ICUs mostly staffed by intensivists still harmful? So there's a lot of strange stuff when you compare these, and I do mostly observational cohort research, so I love the apples and oranges, and I love sophisticated models to address apples and oranges. There are some apples and oranges that even models can't address, and this would be one of those scenarios. So for example, in the nearly all intensivist managed hospitals, half of those hospitals were academic hospitals. In the ICUs where none of the patients were seen by an intensivist, none of them were academic hospitals. They ditto for critical care fellowships. They tended to be much more urban. The patients were much, much sicker. So this is, I'm afraid, one of those scenarios where I get very worried that, that even models, you need a bit of overlap for the model to be able to model what the apples would look like if they were cared for in an orange hospital. And I'm afraid that that overlap didn't exist in this data set. But there's a lot of other strange stuff in this study. There's actually no causal mechanism for harm. So it's absolutely true that the patients in the intensivists, looked after by intensivists, had more PA catheters, had a lot more stuff done to them. But even the patients that didn't have all that extra stuff done to them seemed to incur the same harm of being looked after by an intensivist. So the causal pathway was challenging. I made this point already that these are hopelessly confounded, where even I think models are challenging. I did ask this novel question, which is if an individual, if you were admitted to the hospital and you had to choose between being looked after by an intensivist or not. I'm not sure that that's currently an interesting question, or even that this model of care where you either get admitted to one kind of doctor or another comes up a lot. But it does raise two important questions, this study. How do these non-intensivist hospitals, if it's not just because of their patient population, what are they doing at those places that makes them so good? And I think we need to understand that. I'm going to tell you a little bit about how I think we can unpack that. And is individual patient consultation by an intensivist safe? And does it substitute for an intensivist-led ICU? And I think these data offer us compelling evidence that it's not the same. That if you get admitted to an ICU where you can either be seen by an intensivist or not, just having that availability of the intensivist doesn't appear to confer the same benefit as the other studies suggest. We have lots of other data on intensivist staffing, and these are really, really great data from Miriam Treggiari, who drove me here this morning, and I thought I was going to have the fast trip to Harborview. Sorry, Miriam, it was kind of scary. Miriam asked this question in a population-based cohort of King County hospitals and actually showed that being in an intensivist-led ICU reduces mortality, but being in an open ICU and being seen by a pulmonologist as a consultant didn't do anything for you. Furthermore, what she showed, and this is a key question, and I know if I didn't do this, point this out, Dr. Legerfo would ask me at the end, which is what data do we have for mechanisms for all of these systems improvement? And this is one of the few studies that have actually looked at it. So what Miriam showed was that patients in intensivist-led ICUs were more likely to receive, by the way, at the time not very many people were getting it at all, but were more likely to receive lung protective ventilation than patients in non-intensivist-led ICU. And this question about mechanism, the mechanistic link between systems organization, process of care, and outcome is an important one. Well, what about subspecialty ICUs? I apologize. This is from a talk that I gave at Vanderbilt. I would have plugged in the University of Washington, but I thought this was safer. Didn't feel too safe when I did this at Vanderbilt, though. So this is the way Vanderbilt's organized. These are the way the ICUs are organized at Vanderbilt. They have a medical ICU, a surgical ICU, a neuro ICU, a CCU and a CV ICU, a trauma ICU. I actually think I left 2 or 3 off. I think they also have a transplant ICU and a thoracic ICU. Every one of these has a different model of care. Most of them are open with consultants who see the patients. And everybody transfers to the MICU when they get bored. So, Ken, I didn't mean bored. I meant when they achieve maximal surgical benefit. So this is my hospital. We have one team of intensivists who basically look after all of the critically ill patients in the hospital. Trauma patients, neurosurgical patients, neuro patients. There are 2 ventilated beds in the CCU, and I'll talk about that in a minute. And those patients are transferred strictly after 2 days of mechanical ventilation. So who's got it right? Well, we don't have a ton of data on this. Let me talk briefly about the CCU phenomenon. So these are data actually from Duke, longitudinal cohort data of what patients in the Duke CCU, a CCU I remember, it's evidently changed, although my recollection of it is it looked a lot like this at the time as well, is that CCU patients no longer look like CCU patients. And by that I mean they have acute respiratory failure, they have ARDS, they have pneumonia, they have sepsis, they're on renal replacement therapy, they have liver failure, they look like medical ICU patients. And they show that very nicely over time the population is evolving in coronary care units. And I think this is incredibly important. And I have to tell you, I was quite surprised when I read this statement come out just recently in circulation. Now, there were some intensivists on this panel, but it was primarily an American Heart Association guideline statement. And what they wrote about staffing models for the coronary intensive care unit is this. In particular, the available data suggests that the open model for organization and staffing of coronary units that is prevalent in the US may not provide the best possible outcomes in the setting of current practice and patient demographics. The writing group favors a structure in which an experienced intensivist takes primary responsibility for the care of each critically ill patient in the CICU to co-manage with the cardiologist. And importantly, they also, and I think this is a terrific idea, argue that more cardiologists need to go and get they need to do critical care fellowships. And I think that's probably the ideal model in this scenario. So I think this is interesting about the subspecialty model, particularly as it relates to coronary care units. Now, these are data from Jeremy Kahn, a University of Washington product. I think that's a fair way to say it. And Jeremy's done a remarkable body of work looking at systems issues in critical care. And in this question, he asked the question about in this study, he asked the question about subspecialty boarding, where basically, and what he basically concludes is, don't let a neuro ICU look after your acute coronary syndrome, and don't let a surgical ICU look after your ischemic stroke. And the point is if you have a subspecialty problem as your primary diagnosis, and you're boarded in a subspecialty intensive care unit for whatever reason, you do badly. And I would argue, although I suspect the indication bias could go either way, you might park the patients who are destined to die in those units. I suspect the indication bias might go the other way. You're likely to park the safer patients in that unit. There was no mortality benefit of putting patients into their subspecialty ICUs. So the general ICU did just as well on acute coronary syndromes and acute MIs as the CCU. The one exception probably was CT surgery, where specialized units appeared to do better and the boarding issue did not do well. Now, there's conflicting data on this issue. Actually, what's strange is there's actually conflicting data from the same data set that Jeremy used for that analysis, which suggests that neurointensive care units seem to do better with neuro problems. And these are data from Project Impact saying that if you have an intracerebral hemorrhage, you seem to do better in a neuro ICU than a generic ICU. I don't think this question, this is an incredibly important question. Because like all fields, critical care is getting sub-specialized. And we're facing the same issues that oncologists are facing, that cardiologists are facing, and we don't know the answers. So I don't mean to imply by this, these are the data we have. And I don't mean to imply that we know the answer. So let's look at variation in utilization. So if you look at, and these data are just beginning to become available, looking at admission decisions to intensive care units. And what you see in both of these slides are basically the same data. Which is the percentage of patients in each hospital, each dot is a hospital, and the percentage of patients who are admitted to an intensive care unit for that hospital. And the data are risk adjusted to try to adjust for the risk for being admitted to the intensive care unit. And what you see here, like a lot of these, is a huge variation. The data from Tim Hofer's group on the right looking at VA hospitals where they had pretty good risk adjustment from the VA database, and they actually knew what an ICU was. And you'll see the data range from like very small percentage, a few percent, to 30% of patients in a given hospital are admitted to an intensive care unit. He's got a lot of other nice data showing a lot of variation within ranges of diagnosis and severity of illness. The data on the left, same analysis from Chris Seymour, another UW product with a whole host of co-authors, Bill Ellenbach, Colin Cook. looking at the same exact question using administrative data, less good risk adjustment, a little bit less good an idea what an intensive care unit means in that data set, but the variation is much, and the variation is much broader, probably for that reason. Now, surely some of this variation is an ICU is not an ICU and a ward bed is not a ward bed. And I've been in enough VA hospitals to know that's true even across VAs. And there are certainly patients in different hospitals that are admitted to an ICU because of the perception of the way the ward works. Nevertheless, this issue about low-risk admissions to intensive care unit has been around for 30 years in critical care. And it exists internationally, this variation in admission and utilization. So these are data from Hannah Wunsch, not a University of Washington product, who's an anesthetist at Columbia, who's done a lot of really interesting work. And what this shows is the huge variation in ICU beddedness across countries, with Germany and the United States and Belgium at the very top. By the way, the US is in that weird place over there because we have decided to spend, you have decided to spend money on nursing home beds instead of acute care hospital beds. That's the only reason. So the ratio of hospital beds and ICU beds is a bit odd. That's why we fall off that line. But anyway, the US has a ton of ICU beds compared to Canada, which is nicely in the middle, where we like to be. And you can see how that plays out because the exact opposite line exists in severity of illness. So if you look at Germany, the mortality rates for severe sepsis in patients admitted to the ICU is actually the very lowest. They would probably say this because we're awesome at taking care of these patients. It's probably a health services phenomenon. They just admit lower risk patients to the intensive care unit. So this issue of if you've got more beds, you're going to admit patients to them, and you're going to use the beds you have, and there's wide variation in the way those beds are used, is a consistent signal within the US and in international comparisons. I think that understanding this variation in decisions is incredibly important. It's more important and much harder to do than documenting them. And I just want to mention this study because I have to say this is on a long list of the studies I wish I'd done. This is work by Amber Bernardo, who's a general internist at the University of Pittsburgh. And this is amazing stuff. So what she did was, I don't know if any of you read that New Yorker article by Atul Gawande, where he went and sort of visited a high-cost Medicare city and a low-cost Medicare city and tried to understand why they were sort of different. This is that study done scientifically and not by a journalist. So what Amber did was she went to one of the hospitals that had the very highest utilization of care near the end of life, and one of the hospitals with the very lowest. And she went there with a medical anthropologist, and they did sort of ethnography, and they really stayed in the ICUs for a while. They did structured interviews with the staff, and I think found an incredibly rich amount of information. The quantitative nerd in me said there was no way to blind. They knew who the high user hospital was. There were certainly some issues there, but I think the results of this is exactly how we need to get at these issues about admission decisions and culture. And what she found in an article that I strongly recommend to you, both for methodologic reasons and for the results, is that the low-intensity hospitals, the staff seem to agree, yep, this person's dying. They agreed on the diagnosis of dying. They used dying as a diagnosis. They actually used the word death. At the high-intensity hospital, apparently people didn't die. They passed away or they did other things. They believed in using time-limited trials of life-sustaining treatment, and they had higher levels of self-efficacy in their end-of-life skills. And a lot of other things. But I think methodologically, and we're very interested in using this, Avery Nathans and I, another University of Washington product, Avery and I are doing some work similar to this to try to understand trauma triage decision-making. Now, what happens in a developing country, I don't know, say Canada, that doesn't have the same beddedness as the US has? What happens in there when you have a lack of ICU beds? So this is work by Tom Stelfox in Calgary. And what Tom did, which is terrific, and I know that you have them here too, when the rapid response team is activated because somebody's sick on the floor. So imagine this cohort of patients who rapid response is activated because they have some sort of acute decompensation on the floor. That's your cohort. The exposure variable is how many ICU beds are available. Awesome, we had good data on that. And the outcome variable was what happens to the patient. Are they admitted to the ICU? What happens to them? What happens to the mortality in this cohort based on the available ICU beds? So when there are fewer beds, they're less likely to be admitted to the ICU. When there are fewer beds, they're more likely, quite a bit more likely, to have their goals of care changed. But interestingly, within the power of the study, Admission to the ICU for this cohort of patients doesn't appear to affect mortality. Is this rationing? By essence, yeah. We're using a treatment during some periods of time that we're not using it during others based on its availability. You call it whatever you want to, but it's rationing. And it appears to be safe rationing. So if you have a surfeit of ICU beds, I suspect this is not what would happen. And I think these kind of data also explains. There's a lot of other data about ICU crowding and its effect on outcome. This is an area of great interest to a group of intensivists led by Scott Halpern. So a lot of this may or may not relate to the perceived intensivist shortage in the US. And I just want to make a couple comments about that. It tends to come up a lot. Number one, the intensivist shortage merely reflects the same shortage that the US is going to have for all physicians. There's nothing unique about the intensivist shortage. I think Randy disagrees on me on that, but he doesn't get a chance to argue. There's the same predicted shortfall in surgeons, probably the same for ophthalmologists. It's a universal thing, and it's driven by two things: US utilization of healthcare and an aging population. So number one, the intensivist shortage is not unique. And the other thing that I would say, and then I don't know if you know Herbert Stein. He's a sort of a conservative economist. He's my favorite rule of economics. It says that things that can't go on forever don't, like the growth in US healthcare. So it's actually impossible that this rate of change can continue. So my question, though, is showing you all of the data that I've shown you on variation in care, variation in utilization, and perhaps a questionable effect on outcome. Does the US have an intensivist shortage or an ICU bed excess? So I'll leave that as a rhetorical question. So I think I'm probably going to be able to wrap up here. And just by saying that, number one, although we've been looking really, really hard, this sort of magic bullet for severe sepsis, critical illness, that reduces mortality by an absolute risk greater than 10% and relies on extremely novel biotech interventions, are probably a long way away. They might be a long, long way away. And we've got to, nevertheless, we've made significant improvements in mortality, and I just scratched the surface of the data that we have both on ARDS and severe sepsis. Some of that, by the way, I give credit to our colleagues who are surgeons and anesthetists and oncologists who've all gotten better at the things that they do. So some of this is intensivists riding along the way. These improvements in outcomes, since they're not from novel biotech, come from routine, consistent administration of not very magic, not very sexy therapies, and stopping doing or de-implementation. And by the way, for the fellows who are interested in good research projects, I think while the question 10 years ago was implementation, I think there are a lot of really cool questions now about de-implementation of things like renal dose dopamine and transfusions, et cetera. And so the real question is, what do we do while we're waiting for this? I've tried to highlight some of those issues. One of the challenges of studying system issues is it's really hard to do randomized controlled trials. They're not impossible, but they're really hard. And we need to think about smarter designs. There are a lot of different designs that can be used. I won't go into some of these details, but there are a variety of health services research designs that are a bit more robust, say, and reliable than the standard large observational cohort. We need better and more reliable phenotype measures, particularly when we're looking at things like complications around ventilator-associated pneumonia. I think we need to really strive to understand variation and not simply to document it. And I've tried to highlight how I think qualitative research and ethnography in outlier centers can be a real boon to this area of research. And we really need larger cohorts with patient-level data that span the treatment spectrum. Most of the data, believe it or not, that we have comes from basically two large data sets in the US, the Apache data set and the Project Impact data set. And I think we really need to go beyond that. The problem with Medicare data, which is so terrific for many questions, is unfortunately its data, patient-level data about critically ill patients is pretty bad. So it'd be great if we had sort of a SEER Medicare data set where instead of having detailed cancer data, we had data on critically ill patients. And we need to start to think about other outcomes besides mortality, organ failure, and ventilator-free days. We need to think about error reduction in patient safety, nursing turnover and burnout, quality scores, family satisfaction. We need to focus on some things like international comparison. And I don't have time to unpack this idea, but I actually think that there's an incredible role for cost minimization research in critical care. And by that I mean to understand ways where we can significantly reduce costs safely in the ICU and have that be a valuable outcome. So I'm feeling a bit like the prodigal son returning. I can't tell you how excited I am to be back. Seattle just smells differently. And And by that, I mean a good thing. So, so I want to thank Randy, Rob Glenny. I know he's away, but I'll see him soon. And the entire pulmonary division, the Department of Medicine for inviting me. It's really a pleasure to be back. Hey, Dave. So thank you. You know, if I were smart, I would have had the backup slides. Not as much as we should. We have some data. The data there's pretty good data that nursing ratios can affect ICU acquired complications, primarily nosocomial infection rates. Once you get below these, I always get confused with these ratios, but essentially a double for a nurse, right? So one nurse for 2 critically ill patients. Once you get below that, and I'll tell you, you know, depending on the country you're in, that's quite common. Once you get below 1 nurse to 2 patients, you see a pretty abrupt increase in nosocomial infection complications. We have the data that everyone knows about rounding pharmacists in the ICU, and I think that's data that you believe if you believe it. I think if you want to be terribly critical about it, you know, it's Lucian Leap stuff from Harvard, but I think that's valuable. There's not that much data. You know, respiratory therapy is kind of a U.S. You know, phenomenon. We have them in Canada too, but it's not a universal phenomenon. There's not a ton of data that I know, and then there's a lot of data. There's some data about how the teams interact, and not surprisingly, teams that interact better are associated with lower medical error documentation. Essentially, was that what you were getting at? Yeah. Yeah, so one of the things I didn't mention about our units, maybe I had it written up there, that's an excellent question. So in our physicians are sort of generic. We don't let our trauma surgeons who are intensivists attend in the CVICU, perhaps they've chosen not to. But our intensivists are generic, our nurses are not. So if we get a bad head who has an EVD and ICP monitoring, we do have, the nurses are specialty trained. The CVICU nurses are trained and have balloon pumps. So the nurses are subspecialized, but the physicians in our place are mostly generic. Was that what you're getting at? Or were you getting at the nurse practitioner thing? Well, in what way do you think? We have combined ICUs, but we just allocate the nurses that way. So we have, that's the way our unit is organized as a generic unit, but we allocate the nurse to the patient based on their individual skill set, as opposed to the physical location of the unit.
Hi.
Hey.
Could you comment
Jenny,
on 24-hour intensivist staffing
Right.
and what data we have on that in terms of outcomes or cost or other?
Excellent question. So thanks, Jenny. So another important study, the lead author in the New England, again, Jeremy Kahn, looking at intensivist staffing and showed, so I should start by saying, number one, the data supporting 24/7 intensivist staffing, very weak. Some before-after data from the Mayo Clinic, and then all of a sudden it just took off. So number one is very weak. In Jeremy's observational cohort study looking at nighttime staffing, the important thing was if you had an intensivist staff unit during the day, having the intensivist there at night didn't add anything in terms of outcome or length of stay. Scott Halpern at the University of Pennsylvania has actually just finished a randomized controlled trial by week with 24/7 versus not. And it's a completely null result. So at least in academic centers, at least in centers where there's intensivist staffing organization during the day, the benefit doesn't appear to be apparent. The strange thing for me in that data is that there are apparently a lot of ICUs that we would say are not intensivist staff that go out and spend money on people to run the place at night. So it may be, like there's an interesting health services question there, which is if for some reason you can't get your act together for economic reasons or political reasons to make your ICU intensivist staff during the day, you can probably achieve some of that benefit by having somebody come in and sort of clean up things at night. Did I present that in too biased a way? But But Ginny, those are the data. The data are that in intensivist staff units, they're now from a randomized control trial and a very nice observational cohort study validated in a large administrative data set. If you're intensivist staffed, the way you are in all the units here at UW, I assume now, is if you're intensivist staff during the day, there doesn't appear to be much value at night. People may still make an argument around the value of training as work hour changes. As work hour changes occur, there may be value there because then the academic units of 10 years ago don't look the same as the ones now. So there could be an argument there. And there may be a business case to be made. That doesn't, we'd make different arguments in Canada, but there may be a business case about throughput and case volume to be made. I think those would be those are the place, but I think it's hard to come up with a compelling argument now about quality in intensive staff units.
I have a microphone, so now I can ask a question. But actually, I had another question, but I wanted to follow up on this 24-hour intensivist staffing and the Scott Halpern's data, because it is completely negative on all the quantitative outcomes that they look to measure, mortality, length of stay. The nurses loved it,
right.
The house staff loved it, the intensivists loved it, and they're planning to implement it.
Yeah.
So what do you do with that?
Well, I was going to leave that part out. It is interesting if you talk to people who have done it. It's a bit like sort of drinking the Kool-Aid. All of the places that I know that have done it are not planning on stopping doing it because of it. And people describe a lot of value. The intensivists like it because they know their patients are being looked at by a staff person at night and so forth. I don't know. We have, it's hard not to think, I should have mentioned this. One of the challenges, by the way, when you think about evidence and system improvements, right, we know there's heterogeneity in patient-level responses to therapy, right? Like if you think about whatever the therapy is, antihypertensive therapy, we know there are patient subgroups, right? And that we have to individualize therapy. The unit of analysis there is the patient. We think we know some of the things that drive an individual patient's response to therapy. We either know that from some data or biologic rationale. We don't have a clue of what those interaction variables might look like for system-level interactions, right? So what are the system-level interactions like in this trial, whether or not you have an intensivist during the day or night, that drive these system-level? And I'll give you a very real-world example from my hospital. So we get provincial sort of report cards in Ontario, and our hospital is terrible at nighttime discharge. We discharge patients from ICU 24/7. And there's some data, again, not terribly compelling, it turns out, with mixed signals that patients who are discharged at night do badly. They either have higher mortality or they bounce back. So we get a nasty, my CEO gets a nasty email every month or every quarter, and he forwards it to me and wants to know what we're doing about it. And I tell him, well, if you give me 30 more ICU beds, I won't have this problem. And we looked at our data and risk adjusted our patients who are discharged at night. We have a rapid response nurse who sees them the next day, and we do close follow-up. There's no morbidity in our hospital, in our data. You could argue about sample size, et cetera. So I think one of the challenges of these systems things are not only what are the important outcome variables, but sort of how do you think about a population of hospitals and applying this data to, as we have to think about applying it to individuals. I hope I'm not the only one who gets this issue about patient-level response to therapy and unit-level. Thanks. Okay. So that's one of the challenges with applying system-level data. Yeah, no, people love it.
What about the benefit of having an intensivist involved in the care of the patient as soon as they're admitted, say, for the first 6 hours or something, to be sure there's a proper evaluation, proper plan, treatment course started?
Any emergency medicine physicians in the audience? We don't have any data. The only data I can quote you on this, is that delayed admission to an ICU. So if you end up staying in an ED longer, those patients do badly. And I realize I'm asking a question you didn't ask because I don't have any data on that. It makes sense to me. And I think that the ED delay data doesn't answer your question. I mean, it makes sense to me that having people involved early, a lot of the treatments that we have, particularly about early resuscitation and antibiotics, are all about early, but there's no reason an emergency medicine physician can't recognize sepsis and intervene early just as well as an intensivist. So I wish I had some data to say that that was good, but we don't know.
Wonderful talk. I just have a more general question about the ease of doing research north of the border. Americans, believe it or not, have a couple of jealousies about Canadians, and I'll pass over. The first one is that Canadians are nice Americans without assault weapons and with health insurance.
By the way, I'm working hard on changing that average.
But the second is, you talk about data sets, and we also have a jealousy that we think that in Canada there are more generalized data sets because of a more uniform system. Is that true or not? True or false?
I should give a whole talk on American misconceptions about Canadian healthcare. Randy, that's the talk I should have given. Yes and no. So you're absolutely right. Everybody who gets seen in Canada essentially generates an administrative data record. So we do indeed have essentially what looks like Medicare data on everybody. The really cool stuff that we have, and my colleague Dave Yerlink has made a beautiful career out of doing lovely pharmacoepidemiology, is after you're 65 years of age, you get your drugs from the province, right? So we have pharmacy data essentially on everybody over the age of 65, and that's probably the data you're thinking about that's really cool and unique. And when you merge that data with the physician billing data, you get the opportunity to do some very novel research. But the OHIP data that we have is really administrative data, and it is what it is. It's great because it's sort of like having essentially Medicare type data. And because we don't have billing data, because we don't have like UB82 type data, there's actually some less detail that we have than some Americans. So like there's a little bit of grass is always greener, but that's the major data set that I know about that really lets us do cool stuff. It's the drug data.
Thank you again.
Yep.